Welcome to all of you. As you can see, Dr. Prathmesh Jain has already started the surgery. I'll just ask Akhilesh or Ashish will introduce just the clinical part of the first case, and then we'll go over to the OT. Yeah, Ashish. PPT, please. You tell them which one you want.
Hitesh, root fix.
Dr. Prathmesh.
Yes, sir.
Can we just wait for 2 to 3 minutes? I'll just introduce the case, and then
Sure,
I think
I'm ready for you whenever you say we'll start.
Yeah, you are going for the root fix. I heard that.
No, basically this is a multiple problem patient.
Yeah.
All which is described in arthroscopy segment is there in this patient. So hopefully we'll be able to demonstrate a lot of things in this.
Yeah. So the delegates are keen to see all that. So please just. We'll just wait for 2-3 minutes. Ashish will introduce the case, and then we'll go. I'll hand over it to you. Ashish, can you just introduce the case? 1 second.
Hello. Hello.
Good morning, Dr. Sundarajan.
Hello.
I'm Dr. Prathmesh. Hello, sir.
Hi, good morning. Ashish.
Good morning. Good morning, everybody. I welcome you all. So this case which we are seeing live now, he's a 27-year-old male, had a trauma 2 months back in which he dislocated his left knee, which was reduced outside and managed conservatively with a knee brace for a month. After a month, his knee ROM was started. Currently, patient has a full ROM with a posterior cruciate ligament, anterior cruciate, and a LCL tear. Dial test is negative. Patient also has a foot drop preoperatively. On examination, the range of movement is 0 to 130 degree. Sorry, anterior drawer, posterior drawer, and varus tests are positive. The valgus stress test and dial tests are negative. You see, there is a posterior tibial sac sign. The audio is not running on PPT. Audio running. So his anterior and posterior draws and signs are positive.
Probe, root fix कीजिए और वो सारा.
And varus stress test was found to be positive. As you can see here, the dial test is negative. On stress radiographs, you can see there's a opening on varus stress radiograph and translations on anterior drawer and posterior drawer stress radiographs. Here's the MRI images of the patient showing anterior cruciate and posterior cruciate ligament tears and LCL tear. So our plan today is arthroscopic PCL reconstruction, ACL reconstruction or repair, and LCL reconstruction. The surgery will be performed by Dr. Prathmesh Jain. Over to you, sir.
So good morning, everybody. So
Okay, OT live, please.
thanks to all the organizers, Vikram sir, Amiya specifically, and I'll just praise the case that they have given it to me. So this case is everything which is a nightmare for an arthroscopic surgeon. So basically a knee dislocation type 3, reduced initially, then put in plaster, then started range of motion. Now this patient has almost all the injuries, all the components of the multi-ligament injury, which are usually addressed by an arthroscopic surgeon. But one thing which is missed, I'll just tell you at this point of time. So I'm just trying to do a valgus of this patient. And if you see here, everybody can see this dent. Okay? And so this dent was not picked up in the MRI and not discussed. Now this is a very, very classical feature of a medial overload syndrome after a multi-ligamentous injury or an...
I request Sameer and Praveen to please moderate this session.
So this is a very, very classical indication that the patient has basically lost his ligament balance and he is loading on the medial side. So this is a very, very telltale sign that there is a medial overloading and there is a loss of the cartilage which is starting from this place. So if I am not addressing this at this time, this will progress like this, and probably later on he will land up into arthritis. The other thing that you must appreciate is this. Can you see these fronts here? So this is the meniscotibial ligament. So the meniscotibial ligament is also damaged, and you can see this healing response here. So this is a meniscotibial response, meniscotibial ligament sprain with a healing response here with the synovitis. Okay?
Yes, sir.
And if you see on the back, whole of the root is avulsed. Okay? So this whole root is avulsed. It should be ideally here, but this is avulsed pertaining to all this knee dislocation things. And this is led to the medial meniscus going out and loading of the medial femoral condyle on the lateral tibial plateau. That is called as a point loading, or that is called as an extrusion, and this is the start of osteoarthritis. So this is the pathology of starting of osteoarthritis in most of the cases. Lateral valgus, please. So now, so what is important here is to address this part. You can see that this is the area of the root from which this is avulsed like this, and I need to repair this root back to its place along with doing a PCL and ACL and LCL surgery to make the knee functional, because one of the important goals of this surgery is not only to achieve a ligamentous stability or a stable knee, but also to achieve a pain-free knee for a long time. That is, we don't want the arthritis to progress in this particular patient. So you can see that this particular patient, this whole of the root is avulsed from here, and we want the meniscus to be attached back here in this particular position. Now, if you go by literature, you can do it by two ways. There is a transtibial technique which you can do. You can put sutures through it and put a knot through it and then repair it. But what I am demonstrating today is what is called as a root fix technique. So, Jig, please.
Prathmesh sir, good morning. This is Dr. Praveen Agrawal.
Good morning, sir.
Sir, have you taken some different portals which you normally take for scopy, or you have taken some other portals?
So this is at present we have not taken any special portal so far. We will be taking the special portal soon.
So are you
So this is basically we are doing it from the lateral portal here. The weaving portal is the lateral portal, and the working portal is the middle portal so far.
So have you made the lateral portal higher than the
A
normal?
little higher, because I need to do the PCL as well. So little higher. Not very much significant, but little higher than what we do normally. Okay. So now what I want is, now this, with this instrument, with this implant, we can make it different ways. So what we can do is, ideally it should be here, but if I put it here, it may be a lot of pressure, lot of forces which are there. So we will be just cheating a little bit on the, okay, hold it please. Jig please. So now I'm just putting my jig. You can use any jig here, but a root repair jig will be preferable.
Dr. Prathmesh, good morning.
Good morning.
Dr. Sameer.
Good morning.
I just wanted to ask, right, in this particular case, we are going to with the ACL, PCL, and as well as the root repair.
LCL
right?
also.
LCL also,
okay.
Right? So there are going to be multiple tunnels in the tibia.
Yes.
So would you like to highlight some tricks and tricks to avoid tunnel coalescence?
So now, for the root repair, I'm not making a tunnel.
Yeah.
So that is one tip, because I want to avoid, your point is absolutely valid, and we want to not make a lot of tunnels so that there is a tunnel coalescence issue. Go.
Yes.
So for this particular implant, we don't need a tunnel. Nical. Needle, please. Chia, please.
Have you done any pie casting, medial pie casting in this particular case? Dr. Prathmesh?
Yes, sir.
Have you done any pie casting?
Yes.
Okay,
a little bit of it. Or a little, there is a multi-ligamentous injury.
Okay.
So luckily, I don't want to do a lot of thing. It was already open.
Okay.
So now this instrument comes with a needle. This needle is loaded now with a chia. You can see that this tissue is very, very flimsy here. So this is a chia passer which will be drill loaded with a loop-in suture. So now you can see it better. Now this is a tunnel. Now this tunnel is about 2.3 millimeter tunnel only. Okay? And we are not over drilling it for the reason that we have already mentioned, that this is a multiligamentous injury. We need to make a lot of tunnels here.
So to avoid to augment the bone to soft tissue healing, is there any need for exposing the subchondral bone?
Yes, now in this particular case, there is already subchondral bone which is exposed.
Okay.
And I need not to do a lot of this, because if you see here, there was the subchondral bone was exposed.
Right.
And there was a healing response. Now this is the anchor that we are talking about. And this anchor fits on nicely there. Okay. The trick is you need to use an artery here to actually avoid pulling it too much. Okay. And that is done. Now this anchor is fixed subchondrally. You can pull it down from the tibia, but you cannot pull it up from the joint. Okay?
Okay.
So this is a very nicely fixed joint here. Fixed cannula, please. I would use a knee scorpion device from Arthrex here, because this particular device gives me a very good angle. Please. Knife, please. Knife, please. Knife, please. Green retrievalist. Now, once we are done with the anchor insertion, the next work here for me is to pass the sutures. Now, it is a double-loaded suture with a thin wire. So this is a very, very low-profile fixation device. And as I told you, it will not be in my view. So this is a knee scorpion device that from Arthrex that we are using here. So this device is very, very helpful in passing into the tight corners of the knee, negotiating into the corners of the knee. Okay, so this is my first bite. I take it out, I'll hold it with the artery. Second, please.
Dr. Prathmesh, we have noticed that you are inserting the cannula again.
Yes.
So any particular reason for that?
Because we don't want the knot entrapments. So here again you can see that is a tight space, and your knots can impinge, the sutures can entangle in between. So here you can see that one suture is entangling in the other suture.
Okay.
So that happens. So if you take out the cannula again and insert it back and try to do it again and again, you will be more safer with the suture management thing.
Right. So every time you are taking a bite, you are.
I'll take one more cannula. I'll take out the cannula. I'll take the previous suture away from
Right. So this is the important tips to prevent the suture entanglement. Otherwise, you get a very good bite, but the sutures are entangled, so you need to take again. Any recommendations for where to take the bite?
So
How
now
much away
I don't
from
want to place it in too much of tension here.
Right.
So because this is anyway a very case which has got a lot of forces involved into it. So I want to do a low tension repair. Green retriever, please. I may take a bite on the lateral aspect. Let's see if I can do that. The tissue is very flimsy on the lateral aspect, but I will
Yes.
try. If I could take one bite, there is a chance that if I take a bite in the lateral part of the tissue, it may cut through.
Yes.
But let's take a try. Green retriever. So if you see here particularly, the thing I was telling you has happened, and we have an entanglement here, okay?
Yes.
So now it is imperative that we reduce it and we take out this entanglement from here. So this entanglement will happen, but you should be patient enough to sort that out, okay? So this is out now. And then I'll just take the other bite from there. Call the scope. So you're done now. Retriever, please. Retriever, please. Green retriever, please. Again, this white one will come into my way. So I'm taking it from the deep part again. So that is good. Now this one on the medial side is my post, and the lateral side is my pulling suture. And you can see that with one suture, the root is sitting very nicely on its place.
Yes.
Okay? You can see that the root which was avulsed initially has set very nicely with a single suture. We are here to tie the other one. Okay? So it is reduced nicely into its place. Green retriever.
So you always use the two sutures?
Always.
Or,
This implant is a double-loaded implant.
Right.
So it will be pre. This actually is a kit, so it comes with all the things included.
Right. So in certain cases, do you need to use two anchors with four sutures?
Yes. I'll show you in my lecture.
Okay.
So in many cases, we have to use a lot of anchors. Please hold the cannula, please, one person. So we always, the message to the delegate specifically is, in cases of multi-ligamentous injuries, we always focus on the ligament things and we ignore the meniscus things. But if you want a long-term painful knee with which can do away with arthritis, I think we must always try and look into the meniscus tears and meniscus injuries as well, because the more you do the meniscus injuries, the better will be the long-term prognosis with respect to the pain and the relief of symptoms are concerned, and also the chances of arthritis will be much less with these conditions, with these repairs. If there is a side-to-side sort of injury, I would use an implant like a sequent, in which we can take a side-to-side stitch as well. But in this particular case, this was the right implant which needs to be used. So if you can see, I am done with my repair on the middle aspect. Okay?
Yes, sir.
So now we will be focusing our attention to the next part of the surgery. Hold it. Now I will be focusing my attention to the next part of the surgery.
Prathmesh sir, what happens to the pulling suture which was used?
We just take it out. We just took it out. Okay?
Okay, sir. Okay, sir.
Now we will be just going into the posterior medial corner of the knee like this. Okay? And this is the view I like to see. Needle please, new needle please. Okay, at this point of the time, you must realize that you should see, you can see that sutures of the root repair. You can see that?
Yes, sir.
Okay, and this is the posterior medial corner of the knee. I would like, when doing my PCLs, I would like to make 2 portals. Knife, please. Knife, please.
Sir, Prathmesh sir, while doing the posterior medial portal, you just enumerate the tips for making.
So now this is a
successful
difficult step. You need to be very careful regarding the saphenous nerve here. That can be very close. And then you have to make your portal according to that. This, and I usually, as I told you, I make 2 portals. So I'll use a Wissinger rod here. Cannula, please. Now this is a low posterior medial portal. The other one that I would make is a high posterior medial portal, which will be coming from there. Okay. So we'll be using 2 cannulas.
Sir, can you show the low portal in relation to the articular cartilage where
so it will be very close to the articular cartilage, if you see there. So this is the articular cartilage and the low portal is right here.
The articular cartilage of tibia, sir, tibia.
It is right there. So I will show you when we go into the posterior aspect.
Okay, sir.
Knife, please.
Have you done intercruciate debridement in this case?
Yes, we have done it. We have done it, and we have done it before getting to live.
Okay, sir.
So this is a high posterior medial portal. Take out the needle, take out the needle. So this is fine. So once I'm done with my portals, I would like, what is the size of 911? So now once I'm done with my posterior portals, I would go ahead and I would make my femur. I would do femur first in both ACL and PCL. Okay? So once I am done with my portal placements, hold it please, flexion please. So I will flex the knee about 90 degrees approximately. And now for the femur, there are 2 techniques described. Hold it from ek haath se yahan pakadna, ek haath se isko. So for the femur, there are 2 techniques described. You can do either outside in drilling, knife please, needle please, needle knife. Or you can use an inside out drilling. For using an outside in, you need to have a special jig. If you don't have this jig, what I recommend is this technique. This is called as a low anterolateral portal technique, and this portal will actually make a very anatomical pointer please. And this portal will make a very, very anatomical ACL. So as far as the PCL is concerned, we all know there are 2 bundles, and I want to recreate the anterolateral bundle, which is somewhere around here. So it is more towards the top, right here. And I'll use a pointer.
Dr. Prathmesh, could you please show us the 2 bundles?
Actually, in this patient, it will not be seen because it is already damaged. But the anterolateral bundle will be more on the top, in this region where I have made my pointer, and the posterior medial will be right here on the lower part.
So
you need to give more, you need to go more on the top of the area.
In case the stump is not available, so what are the bony landmarks you will be
so
using?
I would, at the cartilage junction, I'll go around 7 millimeters, 5 to 7 millimeters posterior to that, and I am more towards my notch. I am to more top. Drill with the.
What is the position of the knee at this point, sir? Sir, what is the position of the knee? Flexion position?
Position is around 90 degree of flexion at present.
Okay.
Around 90 degrees. Now we have made a point. We have made a point from where we need to insert the. So this is our footprint, or you can say. Now I'll be using my bead pin here. Okay. Okay.
Sir.
Key please. Now the bead pin I use is a marked bead pin. So occasionally in PCL there is a issue. There is a issue regarding. Nick mana. So there is an issue regarding the length of the tunnel. Okay?
Yes, sir. Yes,
so
sir.
This is a marked bead pin that I use. This black mark, we have to go up to the knife, please.
This is how much distance from the tip?
So that is what I'm telling you. So this instrument is basically a calibrated, the instrument we call it as a retro gauge. It is a calibrated instrument and is a very useful for a novice or a beginner surgeon to reduce the errors while doing ACL and PCL surgery. So because tunnel measurement is always a issue when we are using an integrated systems. So this is called as a retro gauge. This is called as a retro gauge, and I can retrogradely measure the length of the tunnel, which comes out very good. We are around 45 here.
Okay.
So very nice tunnel length we have got so far here. Okay.
So, sir, can you show outside picture
sure.
that measuring instrument?
Okay.
Okay. This is from which company, sir? Have you yourself made it?
Yes.
Okay, sir.
So this is called as a retro gauge device.
Okay, sir.
Retro gauge device. Okay, and this is very, very accurate because I usually say that that this is like a love marriage.
Yes, sir.
Because you can always re-drill if you are not satisfied with this length. Like in ACL, if you have very small tunnels, you can always go ahead and change your tunnel. So you are not committing to your tunnel.
Sir.
So supposedly I am not happy with my tunnel, I can still take out the wire and drill it again. So this was not possible in the conventional technique. Conventional technique, you have to drill a tunnel, at least a 4 millimeter, and then you can measure. So you are committed to your tunnel. Here you are not committed to the tunnel, and you can measure the length of the tunnel before actually reaming. So you can always re-ream.
So how much minimum distance you want in femoral tunnel?
So now in this particular case, we are using the on-button system.
Sir.
And since it is a 45, this is a good 45 good length tunnel, I will be using a number 20 or 25 on button.
Now, what is the minimum length required? If acceptable minimum length?
Minimum length of the lateral cortex?
Of this bit pin to depth of the femoral tunnel.
Sir, normally we need at least 30 because if it is less than 30, you cannot use a suspension device. 9?
Yes.
9? Niche 10 dena. Upar 9, niche 10. So now we will be reaming the femur. Or femur. You have a 20 number on button? 25? 25? Exobutton. Huh. Exobutton, huh? Okay. So just show the button, please. So this is a long tunnel. We can use a 25 button as well. Or you can use a 20 button. Perfect. 20 will be fine. 9 number reamer, please. उनका दे रहा है अपना दे. 9 number reamer. RT, please.
Prathmesh sir, what is the size of the graft you are using?
This is 9. We
9.
already harvested the graft before starting of the live.
Yes. And this particular case, where there are multiple injuries, what are your graft choices?
So I usually recommend hamstring and tick. Exobutton drill. Exobutton drill. Now this drill is little wider than your normal drill. This is because this button is a button which will give you a more deeper purchase. It's a little wider than the normal button, so the drill is also a little bit more.
What is the diameter of this drill?
This is 4.75. It is more than the classical Endobutton 4.5.
Right.
Prathmesh sir, is there any science behind using the hexabutton? Can we not use the routine Endobutton for this?
You can use it, but these are all different buttons, and this is because this is a cortical device, fixation device. This is a good one of my favorite devices.
So in every PCL for femoral tunnel fixation, you will use this button hexabutton?
No. I can use any button, but I recommend a cortical button fixation.
Yes, sir.
So, कौन सा बटन लिया है? 20 ले लिया? चलो ठीक है. वापस देना बेटा. 9 वापस देना. So I'll just show you the tunnel from here. I want to drill it a little bit more. The tunnel is good. You can see from here.
Sir.
Okay. Give me the 9 number reamer again. Passing wire, please. Knife, please. आगे. Pull it from there. एक मिनट. हाँ. Pull it. Very good. So this is good.
Prathmesh sir, which graft have you taken out for PCL?
So in this patient, we have used the opposite side hamstring and the same side hamstring. So we have taken semiti gracilis from the opposite leg,
yes,
and
sir.
we have taken the semiti gracilis from the same side as well.
What is the minimum length of the quadrupled graft required for PCL, sir?
So PCL we will use ideally minimum 8 to 9 centimeter graft. So here it is probably around 9.
Sir.
So now,
so have you finished the femoral tunnel, sir?
so femoral tunnel is done. Now we have shifted our attention to the tibia. Okay? So now tibia, we will see everything from the back only. Okay?
So the monitor is on which side of the patient?
The monitor is on the same side of the patient. So this is very important trick.
So
and this here you can see the remnant of the PCL right there.
Yes, sir.
This is called as the intermuscular septum, and ideally you can release it. Releasing this will actually make your vessels safer, because if you release it, the vessels will fall backwards. So although it is not needed in my exposure, I do it because it will make my vessels shifted posteriorly, and because one of the complications in this particular surgery is a vascular injury. So to prevent that, I usually recommend that you release this sort of an intermuscular septum from the back, because that will lead to the shifting of the major vessels on the back of the knee.
Sir, we are not getting exact orientation where we are.
So we are on the posterior knee. This is the femoral condyle on the medial side. I'll show you the lateral femoral condyle very soon. So this is the lateral femoral condyle, if you can see on that side.
So in this particular area, you would prefer to use a shaver or RF?
I use a shaver here.
Okay.
RF is actually, you can use it, but again it is more risky because there is a risk of transmission of the heat to the vessel. So if you are using the shaver correctly, I think you are good. So now here you can see that this is your PCL fibers, which are remnants. This is the lateral femoral condyle. This is the medial femoral condyle. Here you can see the medial femoral condyle. And I and this is a repair of the root that we have done. So we need to go here in this particular region. Okay, so this is my region where I would be making my femoral tunnels. Tibial tunnel.
So you are going to preserve the remnant, PCL remnant?
I usually preserve the remnant, but in this particular case, because it's a multi-ligamentous injury, there was not much of remnant which was left. But theoretically, I am a very, very strong proponent of preserving the remnant both for PCL and ACL, for that matter, anything.
Yes.
So if you can preserve the remnant, there is nothing like it. The patient recovery will be very good, and he will have a more normal function. So the proprioception is much, much better if you can do a remnant preserving procedure as compared to a remnant excision with a shaver.
And how are you going to determine that you have gone low enough or distal enough on the posterior side?
So that is what I'm showing right now. So it is always better to go as down as possible, as low as possible, as far as the tibial footprint of the PCL is concerned.
Yes.
So you would go deep here, as low as possible.
So important trick, I think what you are using is keeping the window of the shaver onto the tibia.
100%. That is very, very important, because we don't want to. This is the worst part of this procedure will be a vascular injury.
Right.
So you have to be very, very careful. This is not this is not a beginner surgery. So you need to be very, very careful, and you should be very confident in doing arthroscopy before you embark on doing a PCL reconstruction. You need to be very, very careful of your major vessels.
In the midolateral plane, how you are going to determine the PCL footprint?
So now, as you see that I have a very, very good visualization of my medial femoral condyle.
Yes.
And I have a good visualization of the lateral femoral condyle. This is the lateral femoral condyle.
Yes, we can see that.
This is the medial femoral condyle. And so I'll go in the center. That is it.
Yes.
So I think this is a good place for me. Jake, please. Okay, so this is the PCL, medial femoral condyle, lateral femoral condyle, intermuscular septum, a little part of which we have shaved, and after that we will use our jig to actually make our.
The jig is coming from which portal, sir?
From the medial portal.
Medial portal.
And as you told, this is the lateral one, this is the medial one, and we are absolutely in the dead center. I'll probably try to release a little bit more of the soft tissue here.
Do you use this TKR position in all the cases for the knee scopes?
Yes. It is helpful because it reduces the need of one assistant. You can adjust the flexion and keep it in that position without the help of your assistant.
Right.
So it reduces need of one assistant and it makes your construct or your position more stable.
Any particular knee surgeries where you would like to prefer the knee dangling position?
I do almost everything in this position.
Okay.
Okay, so this is it. This is my position.
While separating the capsule from the PCL, you started from the most proximal part of the PCL, or you started from the middle part of the PCL?
So I start from the top, I'll go in the plane between the PCL and the capsule and I release the plane down.
Sir, can you focus the area from which you started actually?
I started from here,
okay,
on the top, and
yes,
then I go into down, like here.
Okay.
Just.
Sir, is there any trick to prevent, can we land up with debriding the ramp of the
usually
medial
not,
meniscus?
because you know that you know your meniscus. Now this is my meniscus, I have repaired it. You can see my sutures also.
Okay.
So usually I am very safe here.
Sir, is there any difficulty?
And this is called the champagne bottleneck, if you are heard about it. So it is the area of the tibia from which the tibia bends downwards. So this is actually the area where we want our
guide wire to come. Sir, is there any difficulty or is there any trick to do these steps when you have MCL injury which was conservatively managed?
I think it should be as straight as possible. Doesn't matter.
And if a patient is operated for MCL grade 3, sir,
okay,
and then you have to operate PCL after few days or few weeks, then do you encounter any difficulties?
The same thing I do.
Okay, sir.
Go.
Any tips for the tibial tunnel?
Go. I'll just like you to be patient for 5 minutes because this is the key step and the risky step.
Yeah. And
I'll get back after 5 minutes. Okay. Tap. इसको पकड़ो टैप करना बेटा टैप करना है ठीक है टैप करना बेटा Go.
So I think here you are using the jig to retract the capsule posteriorly.
Yes, and I am not drilling.
Yes, you are tapping it.
So this is why I asked you to
right.
Because this is a very, very risky step. If this wire penetrates backwards, it will go straight into your vessel. Jig, the protector, please, or a grasper. Number 10 reamer. Number 10. Is the chota wala nahi hai?
So you will always recommend tapping the last portion of the guide wire.
Yes. Grasper. इससे छोटा है वो चाहिए या तो फिर grasper चाहिए. So there are two ways. Either you can use a protector on the back.
Yes.
Or you can use a grasper like this to hold it in its place. Okay, go ahead. Go slow, ekdam slow. Go slow. Slow, very slow. Okay, हाथ से. Very slow एक बार, ऐसे चला. नहीं, उसे कर दे एक बार. इसे कहते हैं बस slow कर एकदम. बस हो गया. This is it. So we are done. ठीक है, so you can see everything is under vision. You cannot afford to do anything blind in this area. Okay?
So this is a 9mm drill?
This is a 10.
This is
Actually, the
10.
graft is
Okay.
very good.
Okay. So 9 on the femoral side and 10 on the tibial side.
Yes. This is a very good built patient, so luckily the grafts have come out very nice.
So in PCL you will be drilling directly with the 10, not the incremental drilling.
You can do incremental drilling. I am usually a proponent of incremental drilling, but in PCL particularly I want to avoid repeated drilling because
Yes.
you know the vessels are there.
Right.
In ACL it is very easy. Incremental drilling is usually helpful and we use it in most of our patients. But here we don't want to drill again and again because every drilling will be a risk for the
Definitely.
vessel on the back.
So any tips to regarding the length of the guide wire to be attached to the drill while drilling the PCL tibial tunnel?
Huh? So it should be as small as possible, as I told you.
Yes.
It should not be very big.
Sir, is there any guide regarding the length of the bit pin on the bullet of the zig, PCL zig? So can you get some approximate?
We want to go down as low as possible. So here we have used around 20 mm offset. So this is around 15 to 20 millimeter down as compared to the 15 to 20 meter down as compared to the tibial cartilage.
And what about the length of the tibial tunnel? Can you gauge? Can you guess it from the zig?
I don't want to because it is not needed.
Okay.
It must be around 5 to 6, but I am not interested in knowing that length.
Okay, sir.
ठीक है? Green retrieve, please. इसको खोल देना मैं.
Sir, now the graft, if it passed, it will pass between the medial femoral condyle and PCL, sir.
So now there are two techniques. You can pass it either above or below the PCL remnant. But in this particular patient, इसको बाद में डाल देंगे. But in this particular patient, green retriever. So this is my femoral tunnel. You can see that. Very nice.
Sir.
Okay. So normally you can pass it either on the top or on the bottom of the area. But here I would be probably on the inferior part of the. You see that? And then I'll take it out from here. इसको ग्रास पे इसको पकड़ना, कैन लॉक पकड़ना. Green retriever. Grasp, please. इसको पकड़, इसको पकड़. Leg, leg.
Prathmesh sir,
Hanji?
I think we can observe that you have retrieved the suture to the inferior portal.
Yes.
Now you are trying to retrieve it to the tibial tunnel.
Yes, yes. Just hold it like this. So we are done. So here you can see that we are done here. Okay? Almost done here. What you can do is little bit of more. I just want to broaden this area because I want my graft to pass in this particular area. So I just want to make it a little bit broader now. This graft is a very thick graft, so I need to do this step. If the graft is thin, you can avoid this particular step. ठीक है? Okay, बेटा ले लो, graft ले लो. Now this is the on button we are talking about.
Can you please ask the outside picture big? We'd like to see the graft.
This is the exo button that we are talking about.
Yeah, please zoom on to the graft. Yes. So this is the semity and the gracilis.
Yes.
Yes, thank you.
Can you give me the graft sizer, please? Graft sizer. Graft sizer. So you can see that the upper portion is 9.
9.
And the lower portion is 10.
10.
9 is, lower portion of 9 is tight. So let's see. Chalo, go ahead. Usually this passage of the graft is the most difficult step here.
Any tips to negotiate the...
So I'll just show you. So
yeah.
Now, I may also have a problem negotiating here because we are expecting, because as I told you, the graft is very tight. White ही खींचना है, ये मत खींचना, सिर्फ white. हाँ, एक मिनट रुको, just. So here we are good enough. Okay. Now at this point of time, as we were discussing, you can have a problem in negotiating the curve or the killer turn.
Right.
Weisinger rod, please. Weisinger rod, please. So the Weisinger rod can be used as a lever here. Okay, now pull beta. Hitesh pull karna. So now this Weisinger rod is used as a lever to negotiate the killer turn.
Right.
Okay. Just.
So you are trying to change the direction of the pull.
I'm just trying to avoid the killer turn by using this Weisinger rod. Khicho. Pull. हो गया. Stop.
Yes,
so
you can
almost
see the
it has
graft is going
negotiated on the back. Now I'll be going on the front.
Have you marked the graft on the femoral side?
Yes. So still you can see. Okay?
Yeah, we can see
Fine.
the loop now.
ठीक, pull कर बेटा, pull कर. We always pull कर. You can see this is the graft and the loop. Stop. You can see that the graft is going in. There is a mark also. There is a vicryl mark also.
So you mark it at 30?
Around
35?
15.
50 from the
15
button.
है ना? So it is good here. थोड़ा और खींचना बेटा, slide खींचना, बहुत मत खींचना.
The tunnel was 45 and you have marked it at 50.
Easy आएगा. ठीक है, stop. So almost we are there.
You're flipping the button now?
Yes, I'm trying to flip the button because as I told you, this is a very tight place. काउंटर देना यहाँ पे. RT please. काउंटर यहाँ काउंटर देना. काउंटर. Just a minute.
Any delegate want to ask some queries? Any questions?
Because we are almost done with the procedure. So,
can you see this button from the middle femoral condyle where it is exiting? Is it possible to see to the intra-articular view?
Usually not, but we can use a C-arm if you want in the end.
Okay.
So probably it is fixed, okay? And this is the PCL that we have done already, okay? So we are good enough here.
So in case if you are not sure that
and if you can see, we can see that the posterior sag is correcting here. You can see
yes,
the posterior sag is correcting. The posterior
yes.
sag is correcting very nicely here with the pull of this button, and then I can usually fix it up. But fixation usually I'll keep it in the end with the biocomposite screw.
Okay, so what fixation you are planning?
We are using a double fixation here. We are using a Genesis screw.
Yes.
For the tibia,
right.
And we'll be using supplementing it with a suture disc.
With the suture disc, right.
So you can see that this is nicely fixed, and this you can actually do a correction of the, so the posterior sag which was there is now completely corrected. Okay?
Dr. Prathmesh, before we close, can you just show the picture, PCL from the posterior side?
Sure.
Graft from the posterior side.
Sure. So PCL भी live करना, ACL live करना है कि we are done? हाँ, ठीक. So
Scope a picture, please. Yeah.
This is my PCL from the back.
Right.
This is the middle femoral condyle. This is the femoral condyle. This is the lateral femoral condyle. Okay? And this
yes.
is the PCL.
Dr. Prathmesh, so what will be the next stage we are planning to do for
now
ACL?
Now I'll be doing the ACL.
ACL femoral tunnel. ACL femoral tunnel.
ACL femur, ACL tibia.
Yes.
And then we'll be doing the LCL.
Okay. And what will be the sequence for tibial fixation?
Tibial fixation, I'll use the PCL first.
PCL first.
And then ACL. And then LCL in the end, yes.
And then LCL at the
You can see that the whole, the correction is already come.
Yeah, we can see the tibia translated.
The correction is actually very good here. If you just pull it, you can see that there is a very good offset.
No, last.
Okay?
Yes. Thank you, Dr. Prathmesh, for excellent demonstration of root repair as well as the arthroscopic PCL reconstruction. Now we'll